session at 11:30 today. Today we have an incredible series of for this opening plenary on Friday. We are going to hear today from the boots on the ground, if you will, the physicians and the communities who are working to transform care delivery in their practices, in their communities, and understand from them how we as an industry can continue to support their transformation and to help them integrate population health management strategies into their day-to-day practice and community healthcare delivery systems. I want to first recognize Health Dialogue for their support for this plenary session, and you're going to hear from CEO James Tugendhat later in the plenary session. We are also releasing this morning a report that we developed in conjunction with Health Dialogue based on a survey of over 100 primary care physician practices. You may have been handed the report on your way in. It is also now available on the conference app. If you have not downloaded the Form 12, we've gotten a lot of very positive feedback about it. You can connect with all your other attendees through that app, and all of the reports are available there now as well. In addition to the physician survey report, we have released this morning the market Brazil, and we have also released the latest version of our implementation and evaluation guide, which you'll be hearing much more about in the coming days. At this point, I would like to introduce the moderator of our first panel this morning. Janhavi Kirtane is the Director of Clinical Transformation for the Beacon Communities Program at the Office of the National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services. Janhavi is going to moderate a discussion with 3 representatives from 3 Beacon communities to hear how they are transforming with the support of Health and Human Services to integrate health information IT, health information technology, and data into improvements for their healthcare delivery systems. Janhavi, thank you so much for joining us.
Thank you, Tracy. Good morning, everyone. I actually am just going to hop to it here and get us started. So if we could, I would like to invite my 3 panelists here, co-panelists here, and we are mic'd a very certain way. So Mike Donahue from our Bangor Beacon community, if you could sit here. Yes, please. Actually, Dr. Smitherman from the Southeast Michigan Beacon community, and Dr. Jim Walker from the Keystone Beacon community. And I'm going to let y'all go through their backgrounds, which are in the program, and wanted to begin with a few quick comments about why and how the Beacon Community Program came to bear, and then rapidly turn it over to our community leaders to share a little bit about what's important in terms of healthcare transformation improvement in the future. So 2 years ago, when high tech came to bear, and as a country we decided to take on modernization of the healthcare system in a serious way, there was, of course, the big push, and continues to be a push, for meaningful use and EHR adoption. And that was a nationwide effort. There's a lot of focus on privacy and security, the role of consumers, standards and interoperability. And those are, again, a very national, across-the-board effort. And what we wanted to do was understand what was the possibility of communities coming together and putting all of these different pieces together and saying, what would it be if we had America's most wired community, America's most wired hospitals? But what was the possibility if we made all these places come together and had community leaders say, what was the healthcare issue of most importance, and how is technology going to bring that story to life? So with that context, I wanted our panelists here to take us through, very briefly first, what is it about technology that is important to your community? Because these aren't communities who said, we have a technology solution looking for a problem. We wanted to know what was the problem and how you're going to bring that to bear. And so we'll go through each of 3 very, very different stories about that. And then because each of these communities are very different, there's a couple very specific interventions that I want us to go deeply into. So some are taking on mobile health. Some are looking at skilled nursing and transitions of the frail and elderly. And others we have a pioneer ACO also here. And then I want, of course, at the end to look into our crystal balls and figure out what the future might look like, and some advice to our audience. And we'll be taking actually questions by Twitter. So I think it's #CCA Forum. So please send those along the way if you have them. And actually, to get started, why don't we start with Dr. Smitherman?
Oh, okay. Hello, good morning, I should say. My name's Dr. Herb Smitherman. I'm from Detroit. I'm actually a CEO of an FQHC, which is a community health center. We have about 15 physicians and several nurse practitioners and nurses. I'm also an assistant dean at Wayne State University Medical School. So I wear different hats, but the hat I'm here to represent today is really about the FQHC, the community. And I'm from Detroit, and we're going to a transition, obviously, with the auto industry. We had about 1 million people in our community probably 2 decades ago. We're down to 700,000. About 22% of our population is uninsured. We have high disease indicators within our community. In fact, what we're working on in our community is diabetes and trying to change the actual indicators related to diabetes. And diabetes was overwhelming, or is overwhelming, our community. About 23% of our discharges from our hospital are from diabetics. And so we needed to really change the trajectory of health status within our community, and we saw technology as one of the ways to do that. We had to engage our physicians, systems, and we had to engage our patients. And we needed strategies for each one of those groups. And I think Beacon offered that. From a physician standpoint, very quickly, the physicians are looking for easy-to-use products. They want products that work. They want products that facilitate their care. And oftentimes from physicians you'll hear is that if it takes longer to use this product than it did to write my note, it's not useful to me. They don't want the technology to get in their way. And dictation as it relates to this technology was very, very important. And the other very important issue is interoperability. And that is whatever we have has to be able to integrate and communicate with all the other technology that we're using, which has always been a tremendous challenge to us with respect to adaptation and use. So I would say that we had really challenging disease indicators, that we had to really move that healthcare needle. The paper process, we've already optimized in this country the use of paper. We're going to go nowhere with paper, and we needed to actually bring technology in, and so that was a very important issue for us and a driver for us being a part of the Beacon project.
Great. So, Mike, maybe you could take us through with where the Bangor Beacon community in Maine, how did that come to bear, and what are some of your priorities?
Sure, thank you. Again, good morning. I'm Mike Donahue. I'm the Vice President of Payer Relations and Contracting at EMHS, and I'm also the Chair of the Sustainability Committee of the Beacon Grant, so that we see those tied together. I think the big were at the start of the Beacon community, we had disparate people doing disparate things, all operating in silos, and the ability to bring the technology to bear to bring everybody's electronic medical record, not necessarily on the same platform, but it worked out that way, which was nice. To be able to bring things together and to start monitoring things. We started monitoring a large panel of things, diabetes, COPD, et cetera. And what we found was we were able to leverage having that information and putting it into a disease registry, which then allowed us to implement care management in the system, not in the system, in the Beacon Grant, which includes a large number of other non-system members, to really see some improvement in what's happening. We've noticed dramatic decreases in ED admissions for those populations, dramatic improvements in admissions, et cetera. And I think the real point is that you're having the information available and putting it in front of both the providers as well as the care managers allows you to really do some exciting things, which we've used as a base to move forward with our Pioneer, which I'll talk about later.
Great. And Jim, if you could explain where the Keystone Beacon Community Story in Pennsylvania, how that started.
Thank you, Janhavi. Geisinger serves about 40 counties of the 67 in Pennsylvania. They're underserved, undereducated, underinsured, underemployed. And for lots of reasons, we've been providing electronic information services to organizations across the region for decades. With Beacon, what we wanted to do was to see if we could take our care process redesign disciplines and the information system that supports those, medical home is one form of that, out to the whole community and invite every hospital, every clinic, every skilled nursing facility, and every home health agency in a region to participate in shared care processes and shared information services, regardless of competitive status. And so that's what we've done, and it's been very exciting to just really see transformation in terms of competitors' willingness and eagerness, actually, to share care processes, share the information, and really do what's right for the patient.
Right. So, you know, as the name would suggest, the Beacon Community Program is about communities, and when we think about population health, we heard, you know, lots of independent activities now starting to come together, competitors starting to say, oh, well, we actually have to focus on some outcomes together. And then the realities of where technology is and the concerns about adoption and making it usable, all in the service of improving health, improving care, and reducing costs. So what I'd love to do now is just go deeply into, I know there's lots of different, if we could go briefly around and talk about some specific uses of technology and where you're seeing some improvements. So Jim, I'll start with you. I know we've talked about some of the work you've been doing with skilled nursing facilities and home health and what those transitions of care for the frail elderly mean. What are, and I think we called it the gobbler this morning. If you could explain what the technology solutions you're seeing for that population are.
So one of our happiest discoveries that we didn't anticipate when we started the Beacon, we intended to link skilled nursing and home health into the information ecology from the beginning. What we didn't realize was how isolated from that information ecology to be. Very few have EHRs, and most won't have any time in the near future. They sources and are up to their ears in all kinds of requirements as it is. And what we've been able to do is identify the fact that both of those groups have to send a document to CMS, an electronic patient assessment document to CMS at some set interval. And we have created a simple, cheap extractor that captures each of those documents, takes a clinical extract out of it, and then turns that into a standard document format, CCD, and puts it into the Keystone Health Information Exchange, where that information then is available to the emergency room where the patient is transferred from the skilled nursing facility or wherever. So for the first time, at almost no cost and with no awareness that it's even happening, these organizations are able to contribute information to the ecology. The first system up is Sister Mary Joseph, and it's been working flawlessly for about 2 months, so we're really thrilled. The other question is how do skilled nursing facilities and home health get information from the system? Mm-hmm. And the exciting thing that we're just about to turn live, it works great in test, we have to finish the organizational agreements, is an ADT-based alert. So the idea here is that any licensed clinician, whether they're a PCP or a home health nurse or a skilled nursing facility staff member, can say, these are the patients that I care for, and tell that to Keystone Health Information Exchange. Make sure all of those people have given consent to have their information shared. And then anytime one of those patients is admitted to or discharged from an emergency department or admitted to or discharged from a hospital or registered in many clinics' ADT system, within microseconds, the clinician gets an alert that their patient is wherever they are so that they can do what they need to do to make sure that patient really gets good care immediately rather than finding out a month later that they were in the hospital.
Wow. Well, congratulations. We'll come back to it.
Oh, and I should say both of these are dirt simple technology. The one, the gobbler, the first one, has been balloted by HL7, will be a national standard. Both are freely available. We'd be happy to tell anybody who wants to know how we do them, and we encourage EHR vendors and others to build them into their products.
Well, this is, when we think about the amount of innovation that needs to happen, I'm struck by what you said at the beginning, that this is a piece of information and report that providers actually have to already send. And so the simplicity of the design, I think, is something when there's so much innovation happening, there's probably more opportunities like that we don't actually have to create new things. There's a lot in the system that can be digitized and further leveraged. So, Mike, you know, one of the things we've talked about often is technology is going to be needed as a foundation for 21st century healthcare. It's not just about the modernizations, it's not the electrons slinging around, but in fact in these payment pilots, if you have real-time data for providers at the point of care, if you want to understand the population, you're going to have electronically available data outside your walls to do that. So could you share a little bit about your journey to become a pioneer and how you see the technology piece driving that strategy?
Sure. I think first of all, the Beacon grant, I think, allowed us to jumpstart our capabilities to move forward. In the first year, January 1st, 2013, we became one of the 32 pioneers in the country. At that point, it was, even though we offered to invite all of our Beacon partners in, if you were an FQHC, there were issues with how the attribution was done, et cetera. So, but we found CMS provides a data feed every month, but you need the capabilities of analyzing that information. So we've actually partnered with Geisinger to help us analyze that information. But it's really key because we've got a real solid handle on the electronic health record information, disease registries for all of the quality metrics. But the other side of that is really utilization and cost. You need all three of those components to make this thing work. So under we opted for the selection that there's upside risk but no downside risk in the first year. So in the second year, you have downside risk, which can be substantial. I should add, in the second year, speaking of the Beacon grant, we've brought in Beacon community members, the FQHC and the competing hospital in the same town. So we're very excited about that. But the number of lives has gone from 9,000 to about 25,000. So we're really into some serious dollars here. So the technology piece is really going to be critical as we move forward. The other piece is we now have not only within our own system people that are on our EHR and feeding our own disease registry, we have people that are on disparate EMRs that we now have to have, I believe, come up with a technology that will allow us to aggregate up those disparate EMRs into a single dashboard and move forward. But the technology is the cornerstone. You really can't move forward.
Right. Yeah, I had heard recently we were talking about, you know, it's not just technology, really it's data and information, right? That's ultimately what we're talking about here. And someone had said recently that data and information is going to be for the physician or care provider's mind what radiology did for a care provider's eyes. And it's just, it's impossible to actually deliver the type of care that we would need to see in this country without that.
Yeah, and I think the other piece what we're finding is from just the provider's side of things, the interaction with the care, using that data to interact with the care manager and change the way they deliver care, having each individual work to the top of the license really changes the way care is being delivered in a positive way.
So, so Dr. Smitherman, you know, one of the things I heard a lot about yesterday, I know we are still curious about it, mobile health, right? One of the ways that so much potential, lots of innovation, a new app every other day about technology. I heard, you know, it's all sorts of things happening. Could you share a little with us about the big D for D and what that means in Detroit and what you've been learning about the possibilities of mobile technology?
Yeah. First of all, if we're going to manage population health, that requires data. Innovation requires data. Delivery system change requires data. And I believe overall, I'm a physician. I'm a practicing physician. About 65% of my time is seeing patients. And it is, especially with a paper system, extremely frustrating. If you can imagine that I have a patient in front of me that just came from their cardiologist whose records in the paper system are actually in their office. I have no access to that at the point of service, and I'm being asked to make very life and death critical decisions regarding this patient's health. And so point of care at the time information is going to be critical. And I just believe that the physician's office is where this battle is going to be won or lost in this country. We have about just over 1 billion visits within the United States, healthcare visits, et cetera. And about 120 million of those are in emergency rooms nationally, and about 35 to 40 million are in hospital discharges. About 830 or so million of these encounters are in the outpatient arena. They're in physician offices. And that's where all the action is. But in order for us to change the healthcare needle, we've got to involve the patient. In my community, we have a significant amount of uninsured. About 22% of our population is uninsured. The uncompensated care cost for our healthcare community is about $600 million in free care associated with this population, and significant deficits in health status and health outcomes in this community. And so we said, oftentimes it is this is a very difficult to reach population, and we need innovative ways to interact with our community at large, especially those who are underserved. And so one of the things is that about 40–50% of our community who are uninsured don't have cars. About 30% don't have a landline, but most of them, almost 90+%, have a cell phone. And so one of the things, and I always tell this little story, is that we have cats, and I get texts, at least my wife does. She gets text on her and her cell phone from our vet, notifying us of the appointments for our cats. And so I'm sitting there, okay, this is like, I'm scratching my head going, okay, so a text comes across indicating that my cat needs an echo, which these are basically alley cats to me. So I'm sort of like, you got to be kidding. Right. If he has some congenital illness, it's going to be in a cardboard box out in the backyard. We're going to say this, and it's going. But I'm sort of saying, we're communicating with our, information about our pets over our cell phones. Why can't we, communicate about our patients? Why can't we have interaction between our patients? So what we've done is we've instituted something called mobile health, and it's text for health. And it's under the rubric of fighting D in the D, that is fighting diabetes in Detroit, where what we've done is set up a mobile technology so that any person within our community, and what it does is there's an initial health risk assessment, so it actually, you put in your weight and LDL and a lot of information that you readily have, and it gives you a risk assessment. So that you put the data in, you send, you get a text message back, which gives you some kind of risk assessment, and it tells you, basically whether you need to see someone now or what you need to do. Mm-hmm. It tracks your improvement over time, and it also is a resource base where you can interact with it and try to find the closest physician to where you live, and the closest physician that will take underserved populations or decreased reimbursement, et cetera.